Hello! So the first one was like 15 minutes long, so I'm redoing it because you don't want to listen to me for 15 minutes. Okay, so, hi, my name's Emma Whitteman, and I'm in my car because I have to go somewhere in like 20 minutes, and I don't have a place to do it. And I need to send this in soon. Okay, so, I'm at Belton Hospital in Belton, and I love it there. My nurse is Ashley. I'm on med-surg/tele, and I'm loving it. So, the questions for today, number one, answer two of the following questions. I'm going to talk about describing a patient care situation this week in which the patient care was unfamiliar to you. So, I had hospice care for one of my patients. That's the one I chose to do my assignments on this week. And, it was really, really sad. So, oh my gosh, I cried in the first one. I'm gonna start crying again. Okay. So this patient was like 90 something and his entire family was there. He came because of acute respiratory failure and because of sepsis. So, he was do not resuscitate. So they were basically just, having him stay there because he was fighting an infection, and now but we're not going to do anything for the infection. And so his body is steadily, declining. And I was there when the doctor came in, and the family kind of wanted him to stay because they didn't want to transport him. And I think the doctor, I guess I got educated that you don't. That's a bed that someone else needs because they're fighting something big or they're healing from surgery, so they need that bed. But at the same time, you don't want the patient to die on an ambulance drive to a nursing home or to a hospice care facility. So. That's kind of a difficult situation because of money and insurance and stuff. So that was a really good education moment for me to learn. But the doctor was super kind, understanding, and took the time to answer questions. And it was a very unfamiliar situation for me, and so I learned a lot. But the patient, it was just so weird because we were having to not prolong their life, and we didn't do interventions to help them with fighting an infection or healing or any of that. Instead, we're going to let the body shut down and the system shut down, but we're going to make you comfortable for when that happens, and we're going to make sure that we go peacefully. So that was so different for me. All my family members who have died, I've been shielded from all of that. So I was able to say my goodbyes when they were alert and oriented and could talk back to me. And so, except for one. So I have never really been around this. So I am very emotional, and I can just like sense people's emotions around me. And so I could sense so much in that room. It was really hard for me to be in there. Something I know I need to work on and kind of have a thicker skin for, because I'll be dealing with that a lot in nursing, with death and other people's emotions. So it was just this very different situation for me. The respirations were like 30. His blood pressure went from 111 systolic to 78 systolic, and I think it eventually went to like 50 something systolic. So he definitely was decreasing throughout the 13 hours. He had a pretty stable temperature until the end, and it got to 101.4. So he was going. He had a bounding carotid pulse. Those radial pulses were kind of hard to find, and they were a little weak. He was actually warm to touch. I don't know, I kind of got educated. I talked for a while to the nurse practitioner there, and she was kind of telling me about the death process, so I would be ready in case he died and what to expect, which I really appreciated her educating me. And she said that you would, your ears, your lower extremities, or, your toes and fingers, they would start getting cold. And that didn't happen. I would check every time I went in there when I assessed him, since he was my patient, and he was warm. But we did realize that molting, his knees were getting all bruised, like in purple and blue, and that wasn't there at the beginning of the shift, and then it happened. And so I got educated on why that is. And it's because your body's shutting blood away to your organs and not to your extremities, and that's why it's so bony prominences, you know what I'm saying, got all purple bluish like So that was interesting. I learned a lot about the end of life care and the dying process. It was just really hard. I realized that we're just really providing comfort care, and we're making sure the patient, the patient is looked after and just comforted. And so lots of blankets, warm room. We had the door shut. He had nothing but mouth. He was getting, at the beginning of the shift, morphine sulfate every 2 hours, and then he was so air hungry. He was using his accessory muscles, and he was gasping, but he was sleepy though. He was out of it, but gasping for air, that we ended up giving it every hour. So yeah, special relationship with the staff nurses you've interacted with. So obviously Ashley, this shift was just so crazy. We had 5 patients. We had a tech assigned to us, Rhonda. So I actually didn't really interact with other nurses. Rather, I interacted a lot with Rhonda, the tech. I helped her do HCG baths. I helped her change beds, help move patients. We had a lot of patients who were not oriented, and so we had to run a lot to them to make them get back down, or we had a patient who was mentally retarded, and so she was 70 something and was acting like a 5-year-old, and it was so sad. She was she kept on getting up out of her bed, and she didn't understand that she had a catheter in, and so she was trying to pee on the toilet with the catheter in, and she was just so confused, and the catheter bag kept on getting stuck, and she was yanking on it, and so I would have to run in there and be no, sit down. Something I didn't appreciate was that Rhonda was calling her, and other people who would run in there with me, they were calling her sweetie and honey and just kind of belittling names, and I'm just this woman is 70 something, and just because she's mentally out of it doesn't mean you can, I don't know if it was appropriate. Maybe it was appropriate because she colors, and she has this little, bunny that she kisses and wraps up with, a stuffed bunny. So she's mentally, she is young, but I'm just she's a lady who's lived a long life and who's mentally ill, and I just didn't really appreciate how people were treating her sometimes. So I treated her with respect and didn't call her those names or anything. Also, a new pharmacological intervention. So the morphine sulfate for my patient who was dying, she was just mixing it with saline and then administering it so it wouldn't act so fast, because it was IV that we were doing it in. But then when he started getting worse, she changed that to just administering it right into his IV instead of diluting it. So that was, she explained that to me, and that was a new education moment for me. I didn't realize that, why she was doing that, until she explained it. So second question was my goals. So goal number 1, ask questions. Goal number 2, ask to do things myself. Goal number 3, observe. She gave me the analogy of open glass. So come in there with a mindset of, this is an open glass, and have this glass be filled by the time I leave with new things I've learned. So I think that all these goals were met every time I've gone. I have asked questions. I've had made sure that I say, hey, can I do this myself? Or, hey, I've learned this, can I do this? Or Ashley she does this 3-step process. She does it, I watch, I do it, she watches, I do it again, and I explain to her step by step what I'm doing, and I teach her. So I really like what Ashley does. And observe. I observe a lot. I had I have a minute. I had a patient who was in hypertensive crisis, refusing getting a CV scan, and he wanted to leave and use freaking CVS pills to help his blood pressure. I'm like, oh my gosh, sir. His wife was crying. He has so many kids. He's 40 something. So that was very difficult. I got to hear, actually talk to the doctors about it. I actually got to go in their office and hear them all discuss his treatment and what they should do. And then I got to hear her for a long time have to not fight, but talk to him and help him understand, help his wife understand. And we got him to stay. She got him to stay. But the wife was crying, I was crying. It was very emotional in there. And he was just so stubborn. It was so, anyway, so that was an education moment. And I really got to observe that, and I learned a lot. And then, okay, I have like 3 seconds. New goals. I don't really have any new goals. I really like my 3 goals. I would like to do an IV or like a catheter or something, but you know, if that doesn't happen, I have a full year left. And so right now I'm just kind of observing and learning. And I think a lot of people are just like, I did this, but I'm cool taking it slow because there's so many more things than just doing things by observing. And I'm new to all of this. I haven't been a tech or anything, so I'm fine with going slow and taking my time and working my way up. And I will for sure be like, yes, I will do something if someone asks me to do it. But if it doesn't happen for a while, that's fine. Do your previous goals need to be adjusted? I don't think so. I did good goals for my first video that I did. So yeah, I love clinical. I love Ashley, and I'm really happy I'm at Belton. Okay.